Alrighty, everyone, we will go ahead and get started today. Thank you so much for joining us today for our fifth HIV ECHO session. So we are UNMC's Specialty Care Center, and this is our fifth HIV ECHO session over syphilis today. Our didactic presenter is Dr. Joseph Cherabie today, and then our case studies will be presented by Megan M. Smith and Molly Elston from the Douglas County Health Department. We are really excited to have these three subject matter experts here with us today. We are really looking forward to all of their wisdom over all of the syphilis things. And then I will be your ECHO facilitator today, and my colleague Renee will step over if my internet kicks me off. And then our sessions are held on the first Thursday of every month except July of 2025. And then just a quick disclosure, but our HIV ECHO project is made possible through our grant funding from ViV Healthcare, and it is a sub-project of our I'm Capable research project. And then this is just our agenda for the session today. So Dr. Cherabie will be kicking us off with a didactic presentation over all of the tea about syphilis. And then after Dr. Cherabie presents, Megan and Molly from the health department will be presenting us some syphilis-based case studies and information about local resources. And then we'll have some announcements with a feedback survey link at the end, as well as some information about our upcoming session. And then we have some after hours today. As scheduling and time allows, we'll be hanging around for a couple minutes after sessions just to answer some lingering questions. And today, Dr. Netta Fadal will be hanging around for a few minutes. Alrighty, and now just some housekeeping reminders, but we love discussion, so feel free to pop any questions in the chat, but please stay muted unless you're speaking. We love to see your face if you're able to have your camera on or if you're comfortable with that. And then sessions will be recorded with links available later, but we won't be recording any of the case study portion just for confidentiality. And then, like I said, we'll have an end of session feedback survey. And now I will hand it on over to Dr. Fadal and Dr. Cherabie.
Thank you so much, Heather. Thank you, everyone, for joining us. It's great to see everyone again and so many familiar faces. So it's really my pleasure to introduce Dr. Joseph Cherabie, a great friend and colleague. Dr. Cherabie is the PI and medical director of the CDC Midwest Track 2B Capacity Building Assistance Program. He's also the medical director of the St. Louis STI and HIV Prevention Training Center and the medical director of the WashU Prep Clinic. They are an ambassador, a clinical ambassador for the CDC Let's Stop HIV Together campaign that many of you probably have seen, and on the board of directors of the HIV Medical Association. Dr. Cherabie specializes in sexual health care with a focus on LGBTQIA+ health and sexually transmitted infections, as well as HIV and prevention, all within the lens of medical education. They're also the co-author of the Washington Manual on Medical Therapeutics chapter on sexually transmitted infection and HIV. It's really a great pleasure to have you today, Dr. Cherabie, and the floor is yours.
Thank you so much, Dr. Fadul. It is wonderful to be here, and I'm really excited to chat with you all about syphilis and the resurgence of syphilis and congenital syphilis. So I have an unenviable task of trying to cover all of this in 30 minutes, so bear with me. We're going to try our best. But this is meant to also be interactive. If there's any questions, we'll have time for questions at the end, and please don't hesitate to ask questions in the chat as I have it up. Next slide, please. I do not get paid enough to have disclosures, so next slide. Our objectives today are to review the current epidemiology of syphilis and congenital syphilis, to understand the stages of syphilis, and more importantly, where certain diagnostic mistakes are made or where we can improve, to discuss treatment and the time of medication shortages, as well as to describe a syndemic approach and why it may be essential to syphilis care, especially congenital syphilis care. Next slide, please. So what is the state of STIs currently? This is the most recent data we have from the CDC. As of 2023, you could see that we had 1.6 million cases of chlamydia, 601,000 cases of gonorrhea. These both have either plateaued or decreased, but where we haven't seen a plateau or decrease has been in the cases of syphilis. There are 209,253 cases of syphilis, which represents a 61% increase since 2019. And more startlingly, there's 3,882 cases of congenital syphilis, which represents represents a 106% increase since 2019. I will remind people here that we were near the point of eradicating syphilis in the United States in the early 2000s. In fact, the CDC had a syphilis eradication task force. So to see record rates of syphilis and congenital syphilis is just to show how much this disease has taken off within our populations, and just to highlight the problem of what we are currently facing today. Next slide, please. This is just breaking down the rates of syphilis as of 2023 from 2014 to 2023. The most common diagnosis of syphilis is unknown duration or late syphilis, and that's not really surprising. Typically, that means that our patients are presenting without any kind of symptoms and latency and have not been screened before, right? And so then they would qualify as unknown duration or late. Early non-primary, non-secondary syphilis is a latent syphilis where patients are asymptomatic, but have been tested within the last year. And then you can see that primary and secondary syphilis are down at the bottom, but still quite common. Next slide, please. As with many infectious diseases, there are health disparities in terms of who is more disproportionately affected by syphilis. And so while white individuals make up the majority of the population, they still make up the majority of cases of syphilis. But Black and African American individuals, while they make up 12.6% of the population, represent around 31.7% of cases of syphilis. Hispanic and Latino individuals as well have a slight disparity there as well. And then where we see a huge disparity is actually amongst American Indian and Alaska Native populations. While they make up 0.7% of the population, they represent 2.7% of cases of syphilis. Next slide, please. And with increasing rates of primary and secondary syphilis and overall stages of syphilis, especially in women, we start to see increasing rates of congenital syphilis. So the congenital syphilis cases are represented by these blue bars. The dotted line is actually all stages of syphilis, and primary and secondary syphilis is that dark line. And so it's not surprising that when we see increasing rates of syphilis in individuals who could be pregnant, we start to see increasing rates of congenital syphilis. Next slide, please. So what are the updates to STI screening guidelines? Ultimately, there's not that much in terms of updates, but the biggest one is amongst pregnant women. If you click just one more, there'll be an arrow, I think that pops up. There we go. Look at the arrow. So always follow the arrow on these slides. And so for pregnant patients, we know typically that all pregnant patients should be screened at their first prenatal visit. But what is new is this recommendation to screen at 28 weeks of gestation and at delivery if, quote unquote, at high risk. And what they define as high risk is if they live in a community with high syphilis morbidity or risk of syphilis, such as drug misuse, STIs during pregnancy, multiple partners, new partner, partner with STIs, et cetera, et cetera, et cetera. So we always got this question, what the heck does it mean to live in a community with high rates of syphilis morbidity? And they finally define that, and that'll be coming on the next slide. But what I want to emphasize here is that we really, really, really need to take a good sexual history for all pregnant patients, regardless of their marital status, regardless of whatever assumptions we may make. It turns out pregnant patients do have sex. I know, shocking to many here. And so we really want to make sure to get a good sexual history during each visit and understand that each interaction with the healthcare system is an opportunity to screen for syphilis. And that can be seen in the complete update to STI screening guidelines, where you could see the recommendation is for at least annually for men who have sex with men, for transgender and gender diverse people, screening at least annually, and for women screening those at quote unquote high risk, as well as men who have sex with women. So there have been opportunities to implement opt-out screening in certain places like emergency departments with varying rates of success. But ultimately, you start to see that more and more programs are moving towards this. And especially for pregnant individuals, you really do want to make sure to take a good sexual history and screen at each interaction. Next slide, please. So I told you that we finally have what a high rate means. And I love when the CDC throws this out there. They're like, a high rate of syphilis. And we're like, what does that mean into the ether, right? But we finally defined it. It is a rate of 4.6 per 100,000 people. And so you can look at your respective counties according to this map, and you can see that many of us fall within counties in which the recommendation is to screen at the third trimester and at delivery as well. I happen to be in St. Louis. We are surrounded by green. And so therefore, we recommend screening at third trimester and at time of delivery. Next slide, please. So a couple must-knows, and if these are the kind of things that I want you to remember if you remember anything from this talk. Syphilis must be on the differential for it to be diagnosed. In other words, we keep seeing patients that have been seen by providers, and the providers say, well, I never diagnosed syphilis, and I've never seen syphilis. That's because syphilis has not been on the differential. And syphilis can look like anything. It is called the great imitator for a reason. So it must be on the differential to be diagnosed, and you really should couple syphilis testing with other screening tests for other STIs as well. So anyone with a reactive syphilis serology also should have a full physical examination, a thorough physical examination of pretty much every body orifice, because we keep seeing syphilis pop up in places that we don't necessarily expect it to. I had a patient with condyloma lata in their ear. We had a patient with forehead chancre. We've had patients with chancres on their wrists. So it is important to do a thorough physical exam. And an important part of that physical exam is doing a neurologic review of systems and physical examination, because we know that syphilis can affect the central nervous system at any stage, and it is important for us to rule out neurosyphilis as the treatment will be different. We know that it disseminates at every stage. Like I just said, it can affect the central nervous system, but the highest rates of dissemination are during primary and secondary when people are symptomatic. What we mean by disseminates, it can affect any body part, any organ system. It widely disseminates through the bloodstream. It is why we look for it in our blood supply, right? We get many patients who are referred to us through blood screening. So dissemination can occur at any stage, and the more syphilis we see, the more unusual presentations we see. The way that I learned about syphilis was that the primary syphilis presented as a chancre, painless, and the secondary syphilis was a rash on the palms and soles of your feet. But we actually are seeing more painful chancres, chancres that have superimposed infections on top of them, as well such as Staph aureus or HSV. We also are seeing rashes that can look like a variety of different things, like eczema. The majority of the rashes I see involve the trunk and not necessarily the palms and soles. So remembering that it can present in many, many different ways. A recent rise in cases has been somewhat due to an increased association with drug use. A reminder that people who do use drugs also happen to have sex and have a lot more sex, and also sharing unsterile injecting equipment can definitely, if you have an active syphilitic lesion and you happen to share injecting equipment, it can be transmitted in that way. So two things that every patient with syphilis needs: a neuro review of systems, head to toe. I ask any headache, vision changes, hearing loss, any confusion, any new onset weakness. And that's just a quick run through of a neuro review of systems. And assessment of pregnancy status. If they are capable of pregnant, you want to screen for pregnancy. Again, with the increasing rates of congenital syphilis, this is of the utmost importance. Next slide. This is my favorite diagram with respect to syphilis. And if you read any paper having to do with syphilis, I highly recommend this paper by Dr. Hanem and colleagues. Also, if you ever get to hear Dr. Hanem give a speech, he is delightful and very fun to listen to. So this walks through the how syphilis progresses. And you can see after infection, around 40% have CNS invasion, but the majority will just go through the primary and secondary stages. So let's start with that. Primary syphilis occurs 2 to 6 weeks after infection, typically appears as a chancre and regional lymphadenopathy. You can have a concurrent chancre and rash in around 9% of cases. I actually had a patient one time come in and tell me that he was moving from primary into secondary syphilis. He was absolutely right. His chancre was healing over. He developed a rash. I offered him a job. He said he had a high-paying job. I was very upset with it, but here we are. Secondary syphilis is how most people present because of the painless nature of the chancre, and the chancre can hide in a variety of different folds of the body. People typically present with secondary syphilis, which is most typically presenting with a rash, fever. You can get generalized lymphadenopathy, mucosal lesions such as mucus patches or condyloma lata. Alopecia, it can be quite severe, the alopecia, but usually resolves with penicillin treatment. Hepatitis, in which you see an elevation in ALK phos and not necessarily an elevation in other LFTs. And the nephritis as well can affect the kidney. You can get recurrent secondary syphilis. In other words, the rash can recur in around 25% of cases. Also of note, with darker skin tones, that rash doesn't resolve as readily. So please get used to seeing rashes with various different skin tones. But the important thing to remember is that even when recurrent, those recurrences occur within the first year of infection. And the reason I bring that up is because treatment is different from in early syphilis, which occurs within the first year of infection, compared to late syphilis, which occurs beyond that first year. Then you enter latency. Latency requires there to be no symptoms. You cannot have a latent infection with symptoms, and that's of the utmost importance to remember here. And the difference between early latent and late latent is whether they were tested within the last year or not. Late latent can also be if they've never been tested before in the past and are presenting with zero symptoms. Then that automatically is late latent or syphilis of unknown duration. 70% of individuals develop lifetime latency in which they're asymptomatic, but some do develop tertiary syphilis. That is where you see gummas, which are highly destructive lesions. Cardiovascular syphilis, most commonly aortitis. You can see ocular and otic syphilis. And then you see the traditional idea of neurosyphilis, which is tabes dorsalis, where the posterior columns of the spinal cord are affected. You can see general paresis and meningovascular disease as well. Now, with respect to CNS manifestations, just going back up to the top, again, these can occur at any stage of infection. And you can have isolated ocular otic syphilis. Go back, please. Sorry. There we go. And then symptomatic meningeal syphilis or meningovascular syphilis. Any young person with a stroke should be screened for syphilis because that inflammation can cause a clot and can cause a stroke ultimately. So again, really important to do a thorough review of systems, a thorough neuro review of systems, and then work with DIS, of course, to review the patient's history, especially to determine if a person is early or late latent. Next slide, please. As for syphilis testing, the most frustrating part of our job is interpreting syphilis serologies, as I'm sure as many people on this call. Whenever you get frustrated with syphilis testing, remember that these tests were developed in 1906, and they have not been updated since then. And so I always yell 1906 whenever I'm frustrated because it is really, really annoying. But there are two different algorithms. Both are recommended by the CDC. The traditional algorithm is where you start with a non-treponemal test, in this case, an RPR. If that is reactive, then you get a treponemal test or a treponemal antibody test, typically a TPPA. If that is reactive, then you have a confirmed diagnosis of syphilis. If it is non-reactive, then you have a false positive RPR. Then inevitably the next question we get is what causes a false positive RPR? Things like pregnancy, intravenous drug use, tuberculosis, chronic liver disease, vaccinations, endocarditis, and other inflammatory processes such as rheumatologic diseases. Lymphoma can also cause an elevated RPR. What an RPR test is it's a very non-specific test towards the release of cardiolipin in your system. Cardiolipin is an antigen that your body creates antibodies towards, and basically the RPR test is testing for the presence of antibodies towards cardiolipin. And we see how many antibodies are in your serum based off of that titration out of the serum, right? So that's how we get the titers of 1 to 32, 1 to 64. We titrate it out, and the higher the titer, the more concentration happens to be in your system. But the RPR is non-specific. Cardiolipin can be released by a wide variety of different things. Treponemal tests, on the other hand, are antibodies towards treponemes, right? And so they tell us of a history of syphilis. So traditional algorithm, RPR, followed by the TPPA. If both are reactive, great. So then why do we have a reverse sequence algorithm? For a variety of different reasons. Number one, the RPR can lag a little bit behind treponemal tests. And so we have had patients present with a chancre where like this is syphilis and the RPR is non-reactive. When in doubt, and if you have a high clinical suspicion, then we recommend doing a treponemal test and seeing if that's the case. But also, the reverse sequence is great for high incidence settings. We are moving towards the reverse sequence in our hospital system because it can be automated, that first test, the EIA. And so if the EIA, which is a treponemal antibody test, is reactive, then you could do an RPR. If the RPR is reactive, great, you have a diagnosis of syphilis. If it is non-reactive, then you need a tiebreaker and you need a different type of treponemal test. The treponemal test in this situation then would be a TPPA, which is different than an EIA. If it is reactive, then you have likely syphilis. If it is non-reactive, then you likely had a false positive EIA, which does occur as well. So again, there are positives and negatives of each one. However, in our STI clinic, we use the traditional algorithm. In our hospital system, we use the reverse sequence. Next slide, please. There's other syphilis testing, including these CLIA-waived syphilis testing that can occur in a variety of different settings like the ChemBio, the Diagnostic Direct, and now the Now Diagnostic First to Know, which is CLIA-waived and over the counter. So patients can get it over the counter. I have seen it in my local Walgreens and CVS. But the thing to note here, and what you really want to emphasize with your patients, is that these are treponemal tests. Treponemal tests, typically the dogma is that if you have had a history of syphilis, your treponemal test will always remain positive. That's not always the case. Around 10 to 15% of cases, you can revert back to non-reactive if you treat early enough. However, I like the dogma. I like to remind our patients of that so that they get in the habit of thinking about it, that if you have a history of syphilis, these tests will always be reactive and they will not tell you how active syphilis is in your system. And so you really want an RPR as a screening test in the future. You don't want to do a treponemal test. Otherwise, you'll just get really panicked and confused and frustrated. So I speak about these with all of our patients. The other thing is you still need serologies if you get a treponemal PCR. Yes, treponemal PCR tests are becoming more and more available. A lot of them are laboratory developed tests. However, you need serologies in order to get a full diagnosis. Next slide, please. Okay, so we're going to go through some pictures real quick. Chancre is a hallmark of primary infection. Again, it occurs 2 to 6 weeks after primary infection. It is typically clean-based, raised edge, most commonly painless, but it can be painful. You can have more than one chancre. At the chancre, you do have recruitment of inflammatory cells, especially T cells and macrophages, and so that's why it has an increased association with HIV acquisition. Next slide. Here's some more examples of chancres. Again, just to emphasize what the bottom center picture and the picture on the right is that a thorough physical examination is helpful, looking through the labial folds, looking at the anus in order to see if there are chancres hiding anywhere. And then in the center upper picture, you can see that there are multiple chancres. Chancres do pop up at the site of inoculation. And then just a reminder, because people think ulcerative disease, immediately they start thinking about herpes and panicking. But if herpes simplex virus is on the differential, you really want to look for mpox as well as syphilis as well. And please don't use pain as a means of ruling something in or out. Again, you can have painful chancres just like you can have painless presentations of mpox as well as HSV. Next slide, please. Secondary syphilis, again, the way that I was taught about it, palms and soles of the feet, but the majority of the cases that I see do not involve the palms and soles of the feet. You can get widespread lymphadenopathy, a rash. Typically, it's a maculopapular rash. The rash typically resolves without treatment, enters latency. However, you can see condyloma lata as well. That's that center picture on the right. You can see it's very wet lesions. It's a pressed down pearl appearance is what it's described as. And it's very wet because there are so many treponemes that it actually draws fluid out. And patients will sometimes say that they feel like they're having discharge or leakage. It is really important. Do not touch this with a bare hand. Again, please wear a glove. I don't know why I always have to remind people of this, but when looking at these rashes, please wear a glove because you can develop syphilis and be exposed to syphilis through touching these lesions. On the bottom, you see mucus patches as well. Fun fact, because everyone in St. Louis uses hydrogen peroxide for everything, those can turn white if you swish with hydrogen peroxide. So just something to a fun fact that I learned in my clinic. Next slide, please. And then you can see early neurologic clinical manifestations, including cranial nerve dysfunction, meningovascular syphilis, stroke, and altered mental status. And this is just a review of neurosyphilis that was conducted um, uh, just for reference in the future. Next slide, please. Now, just briefly, yes, wear a glove. This is a case of a 25-year-old cisgender woman who presents for STI workup with no complaints. She reports two cisgender male sexual partners in the last 3 months, uses condoms occasionally. Her exam is normal. Her RPR is reactive at 1 to 256 with a reactive TPPA and a non-reactive HIV test, as well as gonorrhea and chlamydia nucleic acid amplification testing. You call the health department. She has no previous RPRs on file. So, what stage of syphilis and how would you treat? One shot, 2.4 million units, three shots weekly, 2.4 million units. Admit for lumbar puncture and IV penicillin for 2 weeks, or admit for IV penicillin for 2 weeks without lumbar puncture. You can answer in the chat, or you can rock the mic if you need to. Put these questions here so I can hydrate. That's why. Any answers? Anyone have any ideas? Unknown and B, yes, B, perfect. So this would qualify as syphilis of unknown duration because she doesn't have any symptoms, so latent, and she doesn't have a history of syphilis testing in the past, right? So most likely we would treat with 3 shots. Next slide. But wait, there's more. So she returns to the clinic and she is not pregnant. So we did a pregnancy test and a complete review of neurosystem. She states that she's having some vision changes, which she describes as floaters and double vision at times. She also notes that she has a headache more frequently within the last month. The rest of her neuro review of systems is benign. So what should her treatment be now? Would you still do 3 shots? Would you admit for an LP as well as IV penicillin for 2 weeks? Or would you admit for IV penicillin for 2 weeks without an LP? I already rolled out A. All right, so we have a vote for C. Very good. Now, the last time I presented this, the question was, why do we need the LP? And you can LP if you need to as an outpatient. We don't do LPs in our clinic, unfortunately. But if you can do an LP, please feel free to do it. And also starting IV penicillin is sometimes difficult with home health as an outpatient as well. But the reason why the answer is getting an LP is because it's not isolated ocular otic syphilis, which she clearly has, but she also has double vision. So something's affecting one of her cranial nerves, and she has worsening headaches. So you need to rule out other causes of meningitis as well, which is why we really, really want that LP as well. Next slide, please. So the treatment of syphilis, I said this earlier, penicillin with a side of penicillin. It is really helpful to know that penicillin is your first line, and we're very lucky because I think the zombie apocalypse will come the moment we get drug-resistant syphilis. So IM, penzethylin, G-benzathine should be your first line of therapy. Doxycycline is allowable for true penicillin allergies and only for non-pregnant individuals. If they're pregnant or have neurosyphilis, you need penicillin. There is no alternative treatment. So please, please, please use penicillin. IV penicillin is used for neuro, ophtho, and otic syphilis. Azithromycin should not be used. This question came up quite frequently when we were facing a bicillin shortage. Azithromycin, treponema pallidum is globally resistant to azithromycin, especially here in the US. And there's no new data to warrant a change in treatment recommendations. So the next question we get after we say, use penicillin, blah, 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 blah. how long should you wait after treatment to say that you have proper treatment or proper cure? So you need to wait 12 months, and it's a rule of four. So a fourfold decline in titer, successful treatment. Fourfold increase, new infection. But you have up to 12 months to see that fourfold decrease. For cases of late syphilis or individuals living with HIV, you have up to 24 months. So it's a waiting game. And I check every 3 months. I do not check earlier than 3 months because you could get a false elevation of the titer and it will cause you to have a panic attack. So every 3 months I check, and usually I wait for 24 months if it's late syphilis or an individual living with HIV, or 12 months if it's early syphilis. And understand that if the titer is less than 1 to 4, you may not see that drop in RPR titer because it's such a low titer at the baseline. So again, doing a thorough review of systems, check-in, sexual history taking is important. Next slide, please. So click again, again, and again. Perfect. This is also why I love this diagram, because it's easy for us to remember the treatment. So for primary and secondary syphilis, as well as early latent that occurred within the first year, right, you get 1 shot of penicillin, bicillin. If late latent or unknown duration or tertiary syphilis, you would get 3 shots of penicillin weekly. And then if you have any form of CNS involvement, you would do 10 to 14 days of IV penicillin. Next slide. But who must be treated with bicillin with no alternatives? Pregnant patients as well as neurosyphilis. Next slide. So I mentioned this before, my rules of four. A fourfold decline is a cure. A fourfold increase is typically reinfection. And then failure is if you do not achieve a fourfold decline or increase. So again, it's a dilution thing. This is where we do our multiplication tables in our head and our division tables in our head. So if the initial titer is 1 to 32, you want to see it drop to 1 to 8. And again, you have to wait 12 to 24 months for that drop to occur. And so again, if you have any cases in which you fail to see that drop or anything like that, please don't hesitate to reach out to your local infectious disease doctors or to us at the Prevention Training Center. We're happy to help with more complex cases. Next slide, please. This is just showing that doxycycline can be used, especially in cases of actual allergy or in shortages. But doxycycline is effective against penicillin against syphilis, according to this meta-analysis. Next slide, please. So just briefly on congenital syphilis, next slide. I just want to highlight an example case that shows that syphilis should be on the differential, especially in pregnant patients. This is a mom with an adequate prenatal care with RPR that was non-reactive at 8 weeks of gestation. She presented with a vaginal lesion at 35 weeks of gestation to an emergency department. HSV testing was the only thing that was done at the time. No HIV testing, no syphilis testing, no gonorrhea and chlamydia testing. She was treated empirically with valacyclovir. She presented in labor at 37 weeks. No RPR was done at delivery. And then the baby has a workup at 5 months for slow weight gain and developmental delay with hip x-rays indicating periosteal abnormalities, and congenital syphilis was diagnosed. The reason why we were brought on board on this case was actually the child was in daycare, had snuffles, and so had really, really bad nasal discharge. And the question to us was, what is the infection prevention and exposure what we should do to the people who are exposed in the daycare due to this congenital syphilis diagnosis. This could have been prevented simply if she had an RPR when she presented with a vaginal lesion and including syphilis within the differential, again, highlighting that as being of the utmost importance. Next slide, please. Congenital syphilis, though, requires quality care. So you need access to packaged STI testing for childbearing potential. If you're testing for HIV, you should test for syphilis, gonorrhea, chlamydia, trich. If you're testing for HSV as well, same thing. Counseling pregnant people on STI prevention, especially in the latter half of pregnancy. And then do not forget syphilis can occur in pregnancy, and go to the CDC STI treatment guidelines for diagnosis and classification of syphilis. Next slide. I'm not going to go through these scenarios, but there are 4 scenarios based off of the likelihood of congenital syphilis that is in the STI treatment guidelines. I refer to these scenarios every single congenital syphilis case. So please, please, please understand that these are really good scenarios. Scenario 1 is the highest likelihood of congenital syphilis. Scenario 4 is the least likelihood. Next slide. Thank you. Yes, I'm happy you'll share the slides. This is scenario 2. Next slide. A important thing with syphilis and pregnancy is to obtain previous treatment history to help management. Management is the same as non-pregnant patients, but and there are no alternatives to IM bicillin. For early syphilis, you can add an additional dose of bicillin. Some people do that, so they would get 2 shots total. And the goal, if you are treating for late syphilis or syphilis of unknown duration, if you're doing 3 weekly shots, is 7 days between doses of IM bicillin. But if they miss the like second or third dose, you want to get them back within 2 days. So you have up to 9 days. And then there was a study that was presented at CROI that actually showed that the best outcomes were when there was no delay at 7 to 8 days maximum. Ultrasound is used to monitor in the second half of pregnancy, but should not delay treatment. And for patients with early syphilis or high titers, the Jerks-Herxheimer reaction can occur and can cause some fetal distress. So they may need monitoring if they're getting treatment. You want to recheck the RPR at 8 weeks. Again, that's a little early, and understanding that you may not see a 4-fold decline, but you'll have 30 days to initiate syphilis treatment before delivery. And that's your goal. Next slide, please. This is just showing some of the work that was done by one of my brilliant colleagues here at WashU, Dr. Elizabeth Daniels, just showing that some themes emerge with respect to congenital syphilis, such as limited prenatal care, interactions with the prison system, housing instability, intimate partner violence, unemployment, substance use, sex work, and trafficking, and involvement of the Department of Child and Family Services. So again, you need a whole syndemic approach in order to best treat patients with congenital syphilis. Next slide, please. And so you need to ensure quality care. It takes a village, y'all. You need DIS clinicians, community health workers. You need to assess for social vulnerabilities, collaborate, involve community, and always address prevention and stigma. Next slide. And so, haha, see, I made it. All right. So if you have any further questions or any clinical consultations that are necessary, STD-CCN is a free clinical consultation network. It's free, it's quick. We try to answer within 24 hours. And did I mention it's free? So please don't hesitate to reach out. Myself, Dr. Reno, Dr. Hong, Dr. Ramakrishnan here at WashU will all try to answer within 24 hours. And we love hearing your questions because they are wonderful and they help inform some of our cases as well. Next slide.